It's good to be with you this evening. So, next month is Heart Awareness Month, right? Valentine's Day, Heart Awareness Month, February is that month. So, this is sort of the time when a lot of these talks and heart health discussions kind of come to fruition. So, take advantage of it. I know that we do a lot at the hospital, and I know I'm sure, throughout the United States, you're going to see a lot of this discussion about our heart health. So, it's 2020. Why haven't we fixed heart disease? Right? Why are people still dying of heart disease? We'll talk about that tonight. We'll talk about some of the things that we're able to do and some ways that we can prevent it. I wanted to just bring this up. This was published yesterday in the Wall Street Journal. I don't know if anybody saw this. It was an article that featured several different patients one was from Johnstown, and they did a kind of a spotlight on some cardiologists down in Colorado Springs. Colorado Springs, Fort Collins, and Greeley, Colorado, okay, are three areas, as you can see here in the top, we'll say top 10, okay, with increasing rates of cardiovascular disease and death. Now, this is Colorado. This is where everyone's exercise, it's all we do. We're super healthy. In fact, I remember when I finished fellowship, all my professors were like, why are you going to Colorado? There's no one there to even take care of. But not so. Now, they don't dive into the data here. We don't talk about all the Texans and Californians that are probably making the statistics. But I'm just saying that this is what we're seeing. And we think that some of it has to do with the fact that our blood pressure and our inactivity are really kind of driving this force. I want to be clear. I want to talk about, this is my opportunity to talk about what we do in the cath lab and what we do at the hospital. And I'll show you some cool things that we do, okay? How we can save lives and we can fix heart disease. And that's why many of us are living a lot longer than we probably ever should have or ever thought we would be. But as I talk about these things, please don't think that I'm pointing the finger at you and that I'm telling you that you go home right now and you need to change everything. Throw out all the cookies, right? And put all the vegetables in the drawer, because heaven knows I have my share of cookies. But please don't feel like I'm impugning you or I'm trying to make you feel like, you're a bad person. I just want to point out how we can make ourselves healthy, okay, from a heart perspective, and how we can get feeling better. So we'll talk about just some of the risks for heart disease, which many of you are aware of. We'll talk about some strategies of how to prevent it. And then I'll show you some pretty cool stuff of what we do at the hospital, okay, and answer some questions that you might have, or maybe you've had family members or friends that have had some things done to them and you want to ask some questions about it, okay? So to start off, what if I told you that I could increase your longevity by 10 years, I can decrease your risk of heart attack by 60%, I can reduce the risk of arthritis by 47%, almost by half, reduce diabetes by 2/3 almost, reduce your risk of obesity, improve your self-image, reduce anxiety, reduce the likelihood of developing dementia, improve your symptoms, improve your sleep, and also improve your overall immunity from diseases like, colds and coughs and flu. There is one pill for that. Did you know that? I'll show you what it is here in a second. But it is about perspective. Okay, so when you look at this picture, okay, you see something, you just see maybe a branch, maybe some trees and things like that. What I see is the left anterior descending artery that's kind of going on the anterior aspect of the heart, and this is the circumflex here, okay? The heart is an extremely vascular organ, and I don't know if any of you had the opportunity to go down to the the Denver Museum of Natural History a couple years ago, but they had a couple models where what they're able to do is reduce all the other tissues around the cardiovascular system and just leave the vessels alone by putting sort of a plastic alloy or material in there. And this is what your heart looks like. Look how vascular it is. Now, it's unique in that your heart, even though it holds the blood and is the major pump of the body, it gets blood everywhere, it feeds itself. It doesn't absorb blood, it feeds itself. There's a chamber, and we'll show you some pictures here in a second, there's a chamber that pumps that blood out and then it feeds itself. Well, those arteries aren't very big. I mean, they look big here, but they're not big compared to what the heart has to do, and it is vulnerable, okay, to disease, specifically plaque buildup that we call atherosclerosis, right? And some have said that this is probably the weakest system in the human body, okay? And it's certainly the one that does us in. Let me give you an example. So I had a 37-year-old guy, this is a couple years ago. He came to the hospital complaining of some discomfort in his chest and he was having a hard time breathing. 37, right? He's young guy, looked fairly fit. We weren't really that concerned about him. Vital signs were normal, except he had an elevated blood pressure and he was really clammy. His heart rate was a little fast, but other than that, he looked pretty good. So immediately when you get to the hospital and you start complaining of kind of some symptoms, you always get one of these. And this is an EKG, right? An EKG is just a very simple test that was developed, centuries ago that tells us what the electrical activity of your heart is doing, okay? Now, the electrical activity of the heart is driven by the pumping or the plumbing. If you have a bad plumbing problem, the electricity can go bad. Now, if you have a bad electricity problem, it doesn't really affect the plumbing necessarily, but it goes the other direction. If you look at the top one, that's a normal EKG. This patient, we'll call him CJ. It's probably not his real name, I made it up. Anyway, but if you look at this right here at these leads, we call them, you'll see that it looks like a little scooped out indentation. See how the difference between the two? That is an acute heart attack. If this gentleman's artery is not open quickly, he's at risk for either dying or certainly developing what we call heart failure or developing a cardiomyopathy. And it can happen within minutes, okay? As soon as we see this, my team and I are going to be in the hospital and have that artery open in less than an hour and a half. Because data is showing that once you get past that 90-minute mark, your risk of dying goes up fourfold, and your risk of developing heart failure or a bad pump is also fourfold higher, okay? So what you can see here, this is an angiogram, okay? This is literally a tube that's coming up from the artery in his groin, okay? It comes up to the heart, and we just put that tube in the coronary artery, in this case, the right coronary artery. And what you can see is that black serpent-like structure is the actual artery. We squirt some dye in there, and a camera that moves around the patient helps us take the pictures, okay? Well, you can see it's interrupted, right? It's not smooth at one part. So we have to put a stent in there to open it up. See the difference? So before, after. Now that little area right there is a blood clot, okay? Essentially what's happened is an area of atherosclerosis has become either unstable or torn, and just like any other tear or cut on your skin, what happens? Clot forms, okay? Great when you need to have a scab on your skin, bad when it happens in an artery, okay? And so we opened that up. He did great. He went home. Oh, so that's what a stent looks like. We'll show that a little bit later. He went home with a couple medications, and he's been doing very well since. But 37, right? Heart disease is for old people, right? And he even told me that. He's like, I'm too young for this. Like, oh, I know, because you're younger than I am. You're not supposed to be in here. It's estimated that over 600,000 people will die of heart disease in the United States. So that's 1 out of every 4 of us, okay? All right? And if you think about it, everyone, the heart has to stop in order to die, right? But we're just talking about heart attacks and other cardiovascular-related deaths, not necessarily something else got you and your heart finally stopped, right? What the autopsy or what the coroner says actually got you, okay? But it is incredibly expensive to have heart disease in the United States. By 2035, $1 trillion will be spent on this particular disease, okay? Just in the United States. We're not even talking about the world. And again, in the U.S., someone has a heart attack every 34 seconds. So during this talk, okay, you get anywhere between 30 and 40 patients that will have a heart attack during this talk, and somewhere in the United States. And then every minute, obviously, someone can die. So this is a very mortal condition, something that we care about. The typical risk factors are the risk factors that I think you're probably all aware of, right? High blood pressure, high cholesterol, smoking, diabetes, being overweight, obese, physical activity, excessive alcohol use, family history. If you were to look at the top, you want to rank them, okay? Family history is number 1. I can't change your family history, right? I think mom and dad gave you what they gave you. It's kind of how it is, right? I was just talking to my uncle. We're going to end up with cancer in our family, so that's our thing, right? But for some of us, and maybe in the CJ's case, this patient's case, he might have had a family history, okay? The next would be probably high blood pressure, then smoking, and then kind of all the rest of them, okay? So controlling high blood pressure is very important. And it's very important because high blood pressure is sort of like, if you think about a normal pipe in your plumbing system, right? If you ever talk to a plumber, they talk about what the PSI in your plumbing system is, and they want it lower. Because when it's lower, right, corrosion and excess strain on the pipes has been decreased, right? Now you need enough pressure to actually open up a faucet and have blood or water come out, but you don't want it too high because it can cause issues. Same with the pipes in the body, okay? So lower blood pressure is always better for you. And then smoking. That used to be and we're getting better at smoking, okay? Obviously by public awareness, and I think people just aren't doing as much of it anymore. But smoking is definitely a bad actor. In fact, that's the number one question I ask patients that come in. Are you a smoker? Yeah, I'm a smoker. All right, well, you just had your last cigarette, because unless you want to keep doing this, right? All right, so let's talk more about the problem. Does anyone know what this molecule is? Does it look familiar? Any chemists in the room? No? That's glucose, or something that we call sugar, okay? Now I'm going to give you some sobering statistics. In 1820, let's say, around that time, the average American consumed between 2 and 4 pounds of sugar a year. By 2000, we are consuming 100 pounds of sugar per person per year in the United States. I'll say it one more time. I was waiting for more of an effect, but I didn't get it. We consume 100 pounds of sugar per person per year in the United States. And it activates this is why, it's literally like candy and drug for the brain, okay? Your brain wants it, it's good, it tastes good. Now, glucose is the molecule that the cells in our body run, it's the fuel that our body runs on, okay? But sugar in its pure form like that, okay, it's easily transferred into the body, and then your body assumes that, okay, I need to move, I need to get going, right? And we'll talk about when you don't do that, what happens, okay? But it creates levels of dopamine response in your brain that it hits your pleasure center, and it's like, yeah, that's got to have more of that, right? And whether you know it or not, probably every food company in the United States has figured this out a long time ago, right? And that's why our food has become more processed and more refined and has a lot more sugar in it. And then there's code words, okay? High fructose corn syrup. Fructose, which is basically just glucose with an F on the front, okay? You have any number of different words, okay, that are code for sugar, okay? In functional MRI studies that we do, okay, a normal brain, okay, when sugar hits it, okay, it lights up, okay? This is sort of that amygdala, that pleasure center of the brain, it sort of lights up in this area, okay? You'll notice that there's that red portion there. Okay? Now that red portion is normal. That's like a hyper response. Now you look at cocaine, what it does. Where's it hit? Same spot. And then as we get bigger and more obese, guess what? Same spot. Although what happens is the response is less, right? There's less red in there because they become more denuded, that the receptors that are waiting for that sugar or waiting for whatever the stimulant is are more denuded. So clearly, you want to have, this is a normal response. So when you have sugar or you smoke a cigarette or you use cocaine, your brain's going to do that, okay? Over time, it'll begin to do this. But it's the same spot. Same spot. And it's in everything that we eat. Yeah, well... Have you ever looked at like a regular soda, like just a can of soda? That's how many sugar cubes are in soda, like in those sizes. Okay. In fact, when those of you who've had kids, and we used to do this a lot, but I don't think we do it as much anymore. We do oral glucose tolerance tests, right? So you come in and drink that syrupy stuff to see if you have gestational diabetes and so forth. And there is more sugar in these soda cans than those tests that we used to do for the oral glucose tolerance test. And I remember I would watch women drink it and they're going ready to hurl, and I'm going, well, it's just like a soda, but maybe it doesn't taste as good. Anyway, it's in everything. It's in ketchup. It's in any kind of food. It's sugar. Okay? And then what happens is we do this. Okay? And this isn't again, I'm not pointing out anything. But this is not, so we talk about, America being the land of the free, home of the brave, where, we're going to win. We win, right? Americans win. Well, we're winning. And our rates of obesity, exactly, we are number one. Our rates of obesity are higher than anyone else's in the world, okay? Now, for the most part, and again, this graph starts with 2010, but the influence that America has, okay, across the world in the Western diet, okay, you know what we're seeing? Countries that used to have kind of flat rates, they're starting to tick up. They're seeing exactly the same problem that we're experiencing in the United States. It's amazing. The more, let's say, advanced a society becomes, okay, the more that we see this problem. And I'll show you why. This is why. Okay? Even the other day, when was the last time you saw, I think it was about 3 years ago. I was at a conference in Washington, D.C., and I was just waiting at the metro. And I just stood there, and I just stood there, and I was kind of waiting for it. And I kind of looked this way and I looked that way. And I will not kid you, every single person that I was standing next to was going like this. Now, that's fine. That's the world we live in, And in 2007, when Steve Jobs introduced the iPhone to the world, I don't think he knew the influence it was going to have on the entire world, okay? But what that's done is it's made us so we're less active, and our rates are, like I said, of obesity and being overweight are going up. And what that's doing is there's just like a little shift, okay, in what we look like as a society. So in 1986, okay, so the lighter the color, the better, okay? So white's good. We didn't have any data. But as you get kind of more towards this brown color, the crimson color, okay, from kind of a light blue to crimson, that means that you're more overweight, right? So we should see that if you look at just the course of time from 86, okay, to 94, then 2002, and then 2009, you see a gradual shift. And you also see that very high rates of obesity in parts of the United States that are common. We're familiar with that, right? But even Colorado, okay, we're kind of holding our own, right? But still, we still have the same problem, okay? The rates of obesity are going. And again, this is, if you're crimson, that means 38, almost 40% of your population is overweight or obese, okay? And the statistics are sobering. 68% of us are kind of overweight. 80% of our school lunches have exceeded what we would say the federal recommendations for fat and saturated fat are. Now, that's okay. Fat isn't necessarily the one thing that's going to get us, okay? But if your fat content in your food is high, okay, that means you're probably having lots of sugar, okay, which also leads to some other things I'm going to talk about here in a second, okay? 1 in 3 children born in the year 2000 will develop diabetes somewhere in their lifetime. 1 in 3. Okay? That used to be that disease that people get, right? And then they get to do the shots. Well, that was type 1. That was an autoimmune problem where their pancreas doesn't make insulin. Now, our brains are being told, this must be the biggest feast ever because I'm not seeing a famine, okay? And so they just start storing and storing and storing for that famine that it never sees, right? When was the last time you walked down the supermarket aisle and you were like, you can't find the food you want? We don't have that problem. And so our brains, they don't know that. Our brains are just taught and programmed, store when it's feast, and when it's famine, I'll have something to use. Well, we don't have a lot of that famine going on. I don't know if I put that other picture in. Keep an eye on the colors of food too. I often talk to my patients, and when I talk to my patients about colors of food, I always ask them, so what kind of color food do you eat? Oh, blue? You don't eat blue food. Like, what are you talking about, blue? And they're like, I don't know, brown, yellow. I said, that's right. Brown, yellow, right? Look at the kind of that color palette, That's not the stuff you want to eat. Okay, you want to eat color. We'll show that some pictures here in a minute. So I drew this. I did this picture. So 20 years ago, if you went to McDonald's and got some fries, 210 calories, that's what you get. Now, right? And if you increase by 400 calories, you got to walk almost 2 hours and 20 minutes to burn that extra 400 calories. Okay, that's the problem. Okay, just too much. The other problem is it is cholesterol. Cholesterol is a problem. So when we talk about atherosclerosis is the buildup of that plaque in your arteries. It creates the blockages. It's the corrosion within your pipes. Okay, so this is an Inuit woman. You know, the Inuit people who kind of, the Eskimos, Greenland, Alaska, kind of northern parts, their principal source of food is what? Seals, whales, right? And they eat tons of fat, cholesterol, right? But if you look at these hunter-gatherer humans, okay, their levels of cholesterol on the top 5 bars on there, okay, are half of what the adult American is. Half. And they eat a lot of blubber. I even put on there, I think, it has like, here's the elephant right here. Yeah. So we have more cholesterol than elephants. I don't know. But that makes sense because elephants eat a lot of what? That's all they do. They eat plants, right? They're plant-based diet. Yeah. All right. Here's the other problem. Inflammation. Inflammation is basically what hurts in all of us, right? You wake up in the morning, you're like, how did I get hurt sleeping, right? Or you twist an ankle, or you cut yourself, and you have a redness around it. That's inflammation. That's the immune system attacking whatever needs to be attacked in order for infection not to fester, or to let you know that there's a problem and you need to address it, okay? Now, inflammation, okay, is also bad for your heart, okay? And inflammation occurs in your heart, okay, just like it does anywhere else. It tells not so that you feel pain because there's no pain nerves on your heart, okay, but those same vessels that are vulnerable to plaque buildup are vulnerable to inflammation. And what happens is when there's inflammation on those vessels, cholesterol slips in there and kind of creates a patchwork and says, oh, I'm going to calm this down, a little opening here, and creates that plaque buildup. And it's in inflammation is a lot of the root cause of many different diseases that go on, okay, that really affect us. Everything from autoimmune diseases to cardiovascular, diabetes, cancer, you name it. Inflammation is a bad thing. And that doesn't mean you go home and start popping ibuprofen, okay? But inflammation and the reduction of inflammation is important. And we reduce inflammation by our diet. So this is a schematic, okay? On the left here with the arrow, so this is, if you were to cut someone's coronary artery and look at it under a microscope, this is what it would look like with all that red stuff in there. That's cholesterol plaque in that artery, that yellow. And that little hole where the black arrow is, that's the actual tube that the blood flow is supposed to flow in, okay? So what used to be this is now this, right? So, and then this is just a picture of one of the surgeons I work with. He was doing what we call an endarterectomy, and that's a bigger vessel in your body. It could be the aorta, it could be another bigger vessel not related to your heart. And he scooped that out of there, and that's just cholesterol in that artery to get the vessel back open. Now look at the color palette here. Do you see a difference? Okay? So when I talk to patients about, okay, what kind of color foods do you eat, and they say yellows and browns, okay, the blues, the purples, and the reds, and the greens are the good ones. Vibrant colors because it's usually a plant-based food. Even salmon, right? The nice pink hue of salmon, it's very good for you, okay? It's good for you because it has a lot of micronutrients, antioxidants, okay? But it also is lower in what? Cholesterol, sugar, and all the things that are bad for us. People always ask me, okay, Dr. Hodge, which diet should I do? Do I do the Atkins diet? Do I do the South Beach diet? So far, we have only one diet that's actually been shown. And this article from 2013 showed that the Mediterranean diet, which includes a lot of legumes, nuts, fish, those sorts of things that people eat around that portion of the world, okay, kind of that seaside type diet, actually has been shown to have a reduction in cardiovascular disease, okay? The hard part about that, though, is a lot of these studies are very hard to control for, right? There's a lot of confounders, right? So people, unfortunately, they may eat a certain way, but we don't know how they exercise, okay? We don't know how they sleep. We don't know, are they stressed? Are they not stressed? Okay? So it's sort of a mixed bag, but this is the best information we have to this date, 2013, okay? And what I also tell patients is, think about what your plate looks like. So the other day, you're out to eat, and you're sitting there and you sit down, they bring you your plate. And I just looked at mine and I said, that's not right. Because my entree, which is a big slab of whatever, carcass meat on there, is more than half of it sometimes, right? Like you think about a big steak, yeah, right? And then they throw some potatoes or some French fries, right? And then because they gotta have some color in it, they'll just jam in like some carrots or some garnish or something on the end, right? And it'll be like a little wedge shape. Right? Am I wrong? When you go to eat, that's what you get, right? This is what your plate should look like. Now, I'm not saying you shouldn't eat meat. I'm not saying that because I love meat. I'm not saying you shouldn't have starches and breads and pastas. I'm not saying that either, okay? It's got to be in moderation, and it's got to be the right ratio, okay? Unfortunately, this is not how we eat in the United States, okay? It's just not how we eat. And so if you can train yourself to eat like that, or just decrease the amount. So when you go out to eat, think of this. This is great. I get to have dinner, and I get to have lunch the next day because you're going to take half of it home. You don't need to clear your plate. Despite what your mother tells you, there is no child in Africa that's going to starve because you don't eat the food on that plate. It's not going to happen, okay? And I remember being guilted into that as a kid, saying, well, you got to eat that. You got to clean up your plate, right? Just don't take as much. Or train yourself not to eat as much. This is an interesting statistics from the U.S. Department of Agriculture, and it shows us an important lesson, I think, that I want you to take home. So in 2005, Americans spent about 9.9% of their disposable income on food. Okay? Back in 1933, it was almost a quarter, 25%. Why is that significant?
Food is cheap.
Cheap. We're eating cheap food, okay? And our disposable income is being used for other things, okay? And not quality. It's funny, you go to another country, like you go to India or something, and you buy fruits and vegetables, okay? It's cheap, real cheap. You go to McDonald's, it's like more expensive than going to get the carrot at the supermarket. Not here. It is very hard, okay, to eat well on a budget. Go to the store. Whole Foods, right? They're making money off of us idiots because they're like, hey, come and get this fresh produce that everybody else serves, and we're going to charge you 4 times for it, right? It should be opposite. We should be flipping it. In fact, there's multiple studies from urban areas in the United States where low-income families and people that eat low-income food, okay, they have the highest incidence of what? Cardiovascular disease, diabetes, cancer, etc. Okay, impoverished urban areas have the highest incidence of what? Smoking, poor physical activity. You should live in Greeley, Colorado, right? It's open space, got lots of room, you can exercise. Anyway, so I tell people, try to reverse the trends, right? And portion control is probably the number one thing we can do, right? Portion control is the number one thing we can do, okay? We just have to tell ourselves, I'm not going to finish it, or I'm going to save it for later, or, do I really need 16 ounces? Or should I just go for 7 or 8, right? Or 4. Or 2. But I'm also not saying that you can't enjoy life, okay? In fact, I had a lady today, she got some stents in her heart, and she goes, well, why should I change my diet? And I said, you're 85. I don't care. Right? We're not going to change the trajectory, right? But for most of us in here, we're going to change the trajectory, okay? We can change the trajectory, all right? We can reverse or at least stabilize maybe what's already in there, okay? 37-year-old CJ, he's got a long life ahead of him if he does the right thing, or he's got a long life ahead of him in the hospital, okay? Depending on how he chooses to kind of manage his health. But these are some of the things that I tell people. It's the things that I think all of us know, but none of us want to do, right? It's the stuff that when you go to your doctor, you don't want to tell him what you're doing, and you don't want him to talk about it. You just want to, okay, let's just get this awkward exchange over with and let's move on, right? My knee hurts. Alternative therapies is big business, okay? that number is, I'm sure that was from 2013. I'm sure it's higher than that. Okay. Alternative therapies are things like, chelation, or you go down to your Whole Foods or your GNC, and they'll say, take your fish oils and your CoQ10s and all that kind of stuff. And we can answer some questions about that later. There's not a lot of data for that. Okay. Mainly because in 1992, the federal government passed the supplements and it's called the Food and Supplement Act, and none of those supplements that are over the counter or at least sitting on the shelf at the grocery store, none of that's regulated. Okay, so we have no idea what it does. Okay, we've been trying to, but it's really hard to enroll people in studies like that because there's just no money in it. These guys are already making $34 billion. Why do we need to study it? Right? Now, there's a couple of things. Vitamin E is bad for you in high doses. Okay? There is no data that chelation therapy is good for you. In fact, it's probably hurt you. Okay? So if you're doing like micro metal chelation therapy, please stop. That is not good for you. Okay? Echinacea, different things. We haven't seen anything yet that's shown that that's going to be beneficial. Oh, there we go. Yoga, aromatherapy, there's some anecdotal data, observational stuff. But we think more of that's because it decreases the level of stress in people. Maybe not necessarily that it's actually feeling better. But yoga and its relationship to exercise is probably the best thing for you. There's fish oil is sort of a mixed bag. It doesn't prevent cardiovascular disease, but in patients that have high triglyceride levels that can lead to cardiovascular disease, we do use it on a regular basis. All right, so what is it? There is this magic pill. What's going to do all this? I'm sorry, guys. This is it. This is it, okay? You have to stay active. You got to get moving. Our bodies were not designed to do what we do. Sitting is the new smoking for the 21st century, okay? Sitting is the new smoking for the 21st century, all right? We do too much of that, all right? There's a reason that classes are only 50 minutes. Not just because you got to get to the next class, because you got to exercise. Right? When you're in college, you got 15 minutes, you got to get your next class. No, you got to exercise. I'm just kidding. What you should do is you should use that same mentality now. If you've been sitting and I think even the new smartwatches are kind of give you that hint, right? They're like, you've been sitting too long, get up, move around, right? That's important. Our bodies need to move. They're meant to move. You think about our ancestors. They spent all their day doing what? Hunting, foraging, gardening, right? Moving, right? Just to put food on the table. And now, we're like, food's like, hey, I'm hungry, I better go eat. And then I come back to whatever I'm doing, which is sitting, or I'm entertaining myself with sitting, or whatever, right? So we got to move. And it's good for you in so many ways, okay? And I tell people, like, well, what do I do? I said, just do what you love, right? Like, I hate running, so I don't run, okay? But if you love basketball, you love swimming, just find something, okay? Even if it's walking briskly, that's better than nothing. Just for time, I'm going to skip through some of these things. But I tell people at least 3 times a week, replace an hour of television, okay, once a week with some exercise. Do something different. There's a neat little YouTube video called 23 and a half hours. Have you seen that? You have every person, this guy does a great thing. He says every person has 23 and a half hours every day to do whatever they want. The other half hour, they need to exercise. So you have 23 and a half hours every week, or every day to do whatever you want, then a half hour to do exercise. And because of maybe public awareness, but also some of the things that we do in the hospital, okay, the incidence of what cardiovascular disease used to be has gone down, okay? We've actually made strides. So even though 600,000 people are passing away or having a heart attack every year, okay, we're making great strides, okay? The rates are going down, okay? But we are starting to see something that we don't like, and that's a plateau. You always wanted to keep going down, right? But now we're starting to see a plateau. And I guess, according to the Wall Street Journal yesterday, we've seen an increase in northern Colorado, okay? All right, this is the fun stuff. This is what I do. So this is I think, the most elegant and beautiful organ in the body. Don't you agree? Okay? The heart it's a magnificent organ that will beat over 4 billion times in the course of an average person's lifetime. And none of us have to think about it. It just does it. During surgery, when the heart is arrested and the patients go on cardiopulmonary bypass, okay? The moment the surgeons then put blood back in the heart, you know what it does? just starts beating on its own. It's pretty remarkable. It's an amazing machine, okay? And we got to take care of it, because without one, I don't know many people walking around without a heart. So I take that back. I know some people walking around with a heart, but not an anatomical heart, right? Okay? So there's two main chambers. There's what we call a left ventricle, so if you're looking at it this way, this is the left ventricle, the right ventricle. The left ventricle is the most important side because it pumps all the oxygen and nutrients to the body. It's the one that's under the most pressure to do that. The right ventricle just pumps blood from the veins to the lungs. Those are the two main chambers, okay? And there's a series of valves and different things. And so that's the internal structures that can go wrong. There's also the outward structures, the arteries that we've been showing you. And these arteries here, this angiogram shows, okay, these sit on the outside, and that's what feeds that heart, feeds that muscle to kind of go. Up on the the upper left-hand corner, right-hand corner for you, that's a catheter. That's a sheath that goes in the body. Many of the things that we do now are done through that little tube right there. In this operating area called the cath lab, or the catheterization laboratory. That just means we take long tubes, big IVs if you will, and we can work. We can fix a lot of the things that are wrong with a person's heart. So in this case, if someone has coronary artery disease and they have that plaque buildup, we can insert little wires, and over those wires we can have a little tube and a stent. Okay, I'll show you what a stent looks like here in a second. And we can move that blockage out of the way and restore blood flow back to the heart. Okay, so a coronary stent looks like this. It's either a platinum or a cobalt chromium alloy that has a little bit of a drug on it. Okay, and what it does is it's kind of wrapped around a balloon, a lot like those balloons that your kids go to the fair and the guy forms it into an animal, right? Big, long, cylindrical balloons. It's wrapped on that. Back here, when we put that in, okay, we can inflate that balloon, and it'll push that stent metal out, and it'll lock into place. Then we just take the balloon out, and the stent stays there, and it heals within the artery, and now we have an open vessel. These are micromillimeters in diameter, so they're really small, okay? Very, very, almost, if you didn't know, I could show you, I should have brought one. They're almost imperceptible, okay? How little they are. And no, they don't set off metal detectors at the airport. All right, so let's see if I can do. So this is a heart attack. So this is a little bit different. You'll notice that this gentleman, he has a series of wires. He's had a prior bypass surgery, okay? Those wires are what hold the sternum together, okay, so it can heal. And that's exactly what it looks like. It's barbed wire that they just twist it on and just holding it tight. All right, same problem, right? There's no flow down that graft, that bypass graft. So what we did is, it's hard to see. I apologize. Well, it's supposed to do that, yeah. So then what we did is we've threaded a little wire down there, and the wires are hard to see. And then that long cylindrical balloon, you can see it there, and you can see it there. That's the balloon that's inflating the stent. All right, so let me see if this will play. So now it's open. See the difference? Right? All right, and so this guy, he was funny. He goes, I don't know whatever you did, but I can breathe better now. All right, well, we got you fixed, bud. And this, because, and I hope I can do this without being too technical. This is what I love. These are what we call chronic total occlusions. And when I did my fellowship, I trained with some guys that do this. There's only a handful of us in the state and in the country that do this on a regular basis. And a chronic total occlusion would be an artery that's blocked, and it's been like that for 3 or more months. Now, the patient didn't die because, again, the heart's a very vascular organ, and other arteries have kind of supplied that area that may have been starved with blood, and it didn't die, okay? But the artery's blocked, okay? And now they're having symptoms like angina or chest pain, and they can't breathe, and they don't feel well. And so what we do is we have to figure out a way, okay? And so what you can see, this I have 2 catheters in there now, one on the left side and then one on the right side. And as you look here, we're injecting at the same time, and you can see all the arteries of the heart, okay? But this one right here is stumped off, okay? This is stumped off right here. Do you see it? There should be a big artery coming right here that is also the right coronary artery. And so what we have to do in this case is we have to do a technique that we call it retrograde wire of the heart. So this wire, you can see it over on the left. I don't know how, it depends on how good your eyes are with that grainy film. I'm actually taking a wire from the left side of his left coronary artery, threading it through the heart, through the septum, okay, through the other side, and then coming in the back door through the heart. So we have a wire all the way from one side all the way to the other. And as you notice there, it's kind of finding its way down. I'm just trying to find some path to get through there, okay? And what we do is we just kind of move it on down there, and eventually you find it. And you get back up, and you come in through the back door. Let me see here if I can, there we go. Oops, sorry. Okay? And we're trying to wire it here. You can see it's in the wire, and this vessel now needs to be fixed. And so what I did is I took another wire. That's not going to show up well at all, I don't think. There we go. Can you see that? There's a wire all the way through one side, all the way through the other. Can you see that? Basically, in this particular gentleman, because we had two catheters, we had one catheter on this side and one catheter through this leg. And eventually I had a long enough wire that I went through this leg, up through his heart, through it, and all the way down and out through that leg. It's like floss. Okay? And it gives us incredible support, okay, to do the next step, which is putting these big long stents in to get it open. And what it is in this cartoon is, again, because there's two coronary arteries and one on the left and one on the right, again, you take the wire and you literally go right through the meat of the heart. I mean, you just find a little vascular structure that will just allow you to get through there, okay? And you come through and you come through the other side. And by coming through the back door of that plaque, it's a little bit more, let's say, softer, and we can poke through it. And then with that support, so here's what it looked like before, okay? See, there's a stump there, and then here's the after. Okay? Guy's got a new artery. We had to rebuild it with 3 stents, but got a brand new artery, okay? And that just gets pushed off to the side.
So their artery's bigger.
Yeah. Arteries have an amazing capability of what we call positive remodeling. So even though you look at the lumen of that vessel, the artery can have the ability to expand. Okay. Now it can't keep going indefinitely. It will reach a point where it can't go, but we utilize positive remodeling for that. Yep. And then what happens is a new layer of cells grows over that stent and becomes like a whole new process. I mean, a whole new artery. Sometimes people are born with little holes in their heart. We call them PFOs, or patent foraminal valleys. About a third of the population has these. When we're in mom, blood is shunted away from the lungs because the lungs don't do any oxygenation. Mom provides oxygen for the baby, right? So the heart has little holes in it to push it, okay, away from the lungs. Now a little bit gets to the lungs so they can develop, but it's not really going to do a whole lot. Well, sometimes if we're born with that hole, it can create issues. And what we'll do is we'll go in with our device here. It's really hard to see there. We'll go in a little device. It's like a clamshell device, okay? And a wire kind of guides us in there, but this clamshell device, can you see it? It's kind of like got 2 discs, okay? You put one side, you kind of pull the disc out, you kind of lock it, okay? Then you kind of push the other side, and the other disc, see if I can move it here. The other disc is then deployed. You kind of screw it, and boom, close that hole, just like that. And now all through a tube that's only 2 millimeters in diameter. Pretty cool, huh? You can fix a hole in the heart. And then there's TAVR. How many of you have heard of TAVR? Really? Wow. All right. So this is the aortic valve. It's the last door in your heart, okay? This valve right here. And as we get older, or sometimes the same process that atherosclerosis, it builds up on the valve, okay? Before, surgeons had to go in there, they had to open your chest bone, they had to cut the old valve out and put a new valve in. Now, we can do it without cutting your chest open. We can do it through a tube, through your artery, go up to your heart. So what we do is we take that tube up through your artery, up to your heart, and this new valve, like a big stent, is used to push the old valve out of the way, and the new valve is put in place. Now again, these are going to be big files. It may not work here for us, guys. All right, so this is it going in. So what we have to do, we have to arrest the heart. So this patient's heart is being sped up to beat at about 180 beats per minute, so that puts it in its kind of standstill, so the balloon and the valve doesn't move out of the way. A giant balloon is inflated really, really quickly, okay? We hold it up for 3 seconds, take it down, turn off the pacemaker. That guy's got a new valve, done, just like that. Now the record at our institution it was 96, and she went home the next day from the hospital. Okay, what used to be a week in the hospital is now down to a day. Our average length of stay is about 1.4 days for these procedures, when before, a week or whatever. So the technology it's pretty fun. Again, I just love. So you see the aorta there. You see it, and all of a sudden, boom, we go quick. Valve goes in, just like that, and you're done. Pretty cool. And there's a lot of things that we're doing. I mean, we're doing the Sapien valve is the TAVR valve. We do the mitral valve or the mitral clip. If you have a leaky mitral valve, we can put a clip in there and kind of reduce the leakiness of the valve. Some people that have atrial fibrillation are at high risk of developing strokes, but they've had problems with blood thinners. We can put little plugs in their heart where those blood clots might come from to avoid problems, okay? And then sometimes even the surgeons, they've got to the point that they recognize that we're taking all their business. And so what they're doing is they're trying to do smaller incisions and then put a whole new valve in just through an incision that big without having to crack the chest. Shorter lengths of stay, easier on patient recoveries and things like that. And I think patients are feeling better. And then, of course, there's pacemakers. And everyone knows what a pacemaker is, right? What if I told you now we could even get them down to the size of a nickel? And instead of having a big pacemaker here, there are some patients that qualify for what we call the micro device that just goes in the right chamber, or the right ventricle, the right side of the heart. Just kind of deploy that thing in there, and that's it. You got a pacemaker. You don't have anything like up here, no surgery or anything like that. It's the size of a nickel. Now, you can only put 3 of them in because then you run out of room, say. So the battery life is sort of our rate limiting, or the limitation of this device, right? If you need it longer than a certain period of time, we might need to use a different device. But and then there's ablation procedures. I think you mentioned someone had a certain ablation procedure. So this is a mapping system that we can map the electricity of your heart, okay? And we can see where funny heart rhythms that electrically are creating problems, like atrial fibrillation, Wolff-Parkinson-White, supraventricular tachycardia, ventricular tachycardia, etc. And we can map your heart and we can find out where the problem is. And these red spots, okay, are areas that may be in concern. And so then the electrophysiologist can go in with these ablation catheters, sit it where that area is, and with either radio frequency, high-pitched radio frequency, or even cryotherapy or freezing techniques, and kill those cells so they don't create that electrical instability. And then patients are cured. And last but not least, something that we call the Impella heart pump, okay? Before, if you came in and you had a really sick heart, and you're at a point where, just from a hemodynamic perspective, you couldn't support yourself. You're in shock, okay? You're dying, perhaps, okay? Oftentimes, we had to put you on what we call ECMO, or extracorporeal mechanical oxygenation, or basically heart-lung machine, right? Big machines, they put big tubes in. Surgeons are there cutting, and there's blood everywhere, and they're putting stuff in, and you're on a heart-lung machine now, okay? Now, we've got it down to a tube about that big, okay? And basically what it does is it sits inside the heart just like this, okay? Right? This is a picture of one that we did here recently, okay? It sits in the heart, and it just sucks blood out of the left ventricle and pushes it out to the body. I can get about almost 3.5 liters per minute by doing that, okay? And in some cases, we have to do that because the heart's so sick that even if I take a balloon up in a coronary artery or we're fixing a valve, the heart could collapse on us. So now I can do it through a tube that big in your groin. And again, no open chest issues or anything like that. So heart disease is preventable. How are we going to prevent it? We're going to exercise and eat better, right? And should you have a problem, we can take care of you. Okay? Cardiologists and cardiovascular surgeons, we love what we do, and it's always changing. There's a lot of interest in this field. There's a lot of change that happens. I mean, you're probably just as confused as I am sometimes. Am I supposed to take aspirin or am I not supposed to take aspirin? I can't tell because I just read on the news that it's, and things are always evolving and changing, all right? And I think that's what's neat about what I do is we're always trying to figure out the best thing for us, and it's going to continue to be that way. Thank you.